The New Jersey Center for Tourette Syndrome and Associated Disorders, its directors, and employees assume no responsibility for the accuracy, completeness, objectivity, or usefulness of the information presented on our site. We do not endorse any recommendation or opinion made by any member or physician, nor do we advocate any treatment. You are responsible for your own medical decisions. Now I'm going to turn over the introduction of our speaker to Martha Butterfield, the webinar coordinator of NJCTS. Marty?
Thanks, Lisa, and good evening, everyone. Thank you for joining us. Before I introduce tonight's presenter, I would like to take a moment to remind parents that we are still taking applications for our Leadership Academy being held at Rutgers University in New Brunswick, New Jersey from August 3rd through the 6th. The Academy is open to all high school students in grades 10 through 12, as well as just graduated seniors. Now to the introduction of tonight's presenter, Dr. Michael Rubenstein. Dr. Rubenstein received his doctorate from the West Virginia University School of Medicine in Morgantown, West Virginia, and has been practicing for 27 years. His areas of expertise include Alzheimer's and related dementias, Tourette syndrome, global health, and headaches. He is currently an assistant professor of clinical neurology at the University of Pennsylvania. He is on staff at the Hospital of the University of Pennsylvania and Children's Hospital of Philadelphia. Dr. Rubenstein has been involved with the Tourette syndrome community for over 25 years as a primary referral physician, as well as taking administrative roles with the Tourette Syndrome Association. In addition to his work with the Tourette syndrome patients, Dr. Rubenstein has also developed a global health program in neurology and travels to Tanzania, where he provides neurological education and care twice a year in a rural clinic. Dr. Rubenstein, welcome to our Wednesday webinar series. And now, without further introduction, I'm delighted to turn tonight's presentation over to you.
Okay, thank you very much, Marty. I appreciate it. I wanted to thank the New Jersey Center for Tourette Syndrome for the opportunity to speak tonight about the life cycle of tics, and also a topic that's very close to home for me. Just as an introduction, I'll tell you that I wasn't diagnosed until I was in medical school with Tourette syndrome. Most of my childhood I knew quite well what Tourette syndrome was. I had a cousin with fairly severe Tourette's. And my family thought I was just a fidgety kid. It wasn't until I was working with a pediatric neurologist who was extremely astute and pulled me aside at one point and asked how long I had Tourette syndrome. I thought he was joking because I told him I know what Tourette syndrome is, and I thought for sure that I didn't have it. At that point, it was really what opened the door for me to really understand more about Tourette's, understand what all these things that I kind of do and all these things that I feel and had for so long that really didn't understand. I also have a daughter with Tourette syndrome who happens to be listening to the webinar tonight, I think. She has presented with me at the Tim Howard Leadership Academy and is now volunteering to help others with Tourette syndrome, and I'm very proud of what she's accomplished on her own. For the most part, the presentation tonight is essentially what I do for a new patient visit. So I hope it's not too boring for anyone who's listening who's seen me in the past. This will essentially be a tour of Tourette syndrome and will hopefully provide some insight for those who don't suffer from Tourette syndrome, and it will provide some answers for those who do. I've seen Tourette syndrome patients for almost 30 years now, from my residency until now, both children and adults, and I currently see patients, as Marty mentioned, both at the University of Pennsylvania Hospital as well as the Children's Hospital of Philadelphia. So let me run through some objectives and go over some things that we'll talk about tonight first. Basically, I want to understand what motor and phonic tics are. I think we need to understand what sensory urges and premonitory sensations are and what they feel like. And as you'll see, that is probably the most crucial thing in Tourette syndrome that I think is of significance. We'll learn how we label tics. We'll talk about how we make a diagnosis of Tourette syndrome and what are the criteria. We'll talk about associated behaviors and what we see in Tourette syndrome. Why is it important to identify the associated behaviors in Tourette syndrome? The two most important behaviors we'll talk about are the attention deficit hyperactivity disorder, or what's known as hyperkinetic disorder in Europe, and also obsessive-compulsive behavior. We'll talk about managing Tourette syndrome, ADHD, and OCD in the educational setting, and talk about what is a common timeline that we see in Tourette syndrome and the associated behaviors, essentially when these things begin in childhood. And we'll talk about where the problem is in the brain, just briefly related to Tourette syndrome. And lastly, the pharmacologic and non-pharmacologic therapies for Tourette syndrome and the related disorders. So just a piece of historical facts first, talking about Tourette syndrome and Georges de la Tourette. He worked at the famous Salpêtrière Hospital in Paris under Charcot and published his famous article on in the Archives of Neurology in 1885 about Tourette syndrome, and had a group of about 9 patients that he had seen who had had tics in childhood, and then also had tics and neuropsychiatric disorders that he was seeing in adulthood. He referred to the condition as the maladie des tics, and now the disorder bears his name. He was not the first person to describe this. It was described many years prior to that, but he was the first person to publish and to kind of characterize the disorder. It was initially treated with haloperidol or Haldol in the 1960s by Art Shapiro and his colleagues in New York. Prior to that time, there had been no specific treatments that had been used, and many medications had been tried, but haloperidol for many years, for the 1960s and 1970s, were the primary medications that were used for this disorder. So just what is a tic? So the definition basically is any sudden, involuntary, or semi-voluntary, non-rhythmic, repetitive movement, gesture, or utterance that mimics some fragment of normal behavior. A motor tic is just what it sounds like. They can be brief, jerking movements, which are clonic tics, slow movements of sustained posture, or dystonic tics, or an isometric contraction that has no movement at all, which we call tonic tics. A phonic or vocal tic includes any sound produced, or more simply, anything that arises from movement of air through the windpipe. Next, I want to talk about sensory urges and premonitory sensations. The importance of this is perhaps that these are the most defining feature or symptom of Tourette syndrome, and what differentiates Tourette syndrome from all of the other tic disorders. A premonitory sensation or sensory urge is a focal perception or mental awareness that precedes a tic. Patients may describe the urge as a specific sensation, such as an itch, a dryness in their throat, a tickle in their throat, or that their clothes are uncomfortable. Or they may describe it as a non-specific urge, such as a feeling of anxiety or a spring tightening, such as their muscles are kind of becoming more tight, or a rubber band winding up. The actual tic is often described as a release of the tension, and that the tic actually relieves the uncomfortable sensation that we refer to as a premonitory sensation prior to a tic. So essentially, Tourette's patients feel this sensation, and the sensation is what causes the movement. The sensation is present in approximately 80% of patients with Tourette syndrome. They will describe these sensory urges or premonitory sensations that precede their motor or phonic tics. I'm often asked to describe what a tic feels like to those who don't have tics, and the best description I've come up with is that it's similar to an ant or a bug crawling on your leg, and you have the urge to brush it off. That's the urge or the premonitory sensation that Tourette's patients feel. You've noticed that we refer to tics as being semi-voluntary, and this is the ability to suppress a tic for a moment or longer Imagine if I told you that you couldn't brush the bug off your leg and just had to let it crawl there and bother you. That's how it feels to suppress a tic. When you suppress a tic, you feel the sensory urge, and if you try not to tic, it builds up this sensation of this further discomfort that you hold within you, and it builds up like a tightening spring or like a building up of tension. You'd eventually, if you had this bug crawling in your leg for a normal person, you'd eventually have to break down and brush off the bug or do the tics as the anxiety that builds within. The concept of the Tourette brain, and what I explain to patients and to family members, is that the concept of the Tourette brain is that it has a lower threshold for sensation to reach the level of consciousness. And what I mean by that is that a tickle in the throat for a normal person that they might not even be aware of because the brain has filtered it out, realizing that there's all these sensations that are coming from your body. The brain's filtered this out, but in a Tourette brain, we don't filter that out. So essentially what you feel in Tourette's is that these sensations that normal people really don't perceive because they don't reach the level of consciousness, it doesn't bother them. So if you have a tickle in your throat, a Tourette's patient's going to have to clear his throat each time he feels that tickle. And unfortunately, 10 or 15 seconds or 30 seconds later, it's going to come back again. So what are the different types of tics that we talk about? We have motor tics that are simple. So we have simple motor tics that are fast, darting, meaningless. Examples include eye blinking, head jerking, grimacing, jaw snapping, shoulder shrugs, neck tightening, or we have complex tics. These are slower, they're coordinated movements that may seem somewhat purposeful. Things like clapping, hopping, brushing your hair out of your eyes. These would be examples of complex tics. Phonic tics come in the same flavors. We have simple phonic tics, which are fast, darting, meaningless. Again, things like throat clearing, coughing, grunting, yelping, humming, sniffing, sniffling, animal noises. So any simple sound we would consider a simple phonic tic. Complex phonic tics, on the other hand, are a group of noises together, but they are more meaningful linguistically. So they may be things like uttering words or syllables, phrases, statements, expressions. And then we have some more specific phonic tics that are also complex, such as echolalia, or repeating what someone else says, palalia, which is repeating one's own words or phrases, and then coprolalia, which is perhaps the more well-known and luckily less common feature we see in Tourette syndrome, which is the utterance of obscene words or socially inappropriate remarks. So what are the different types of tic disorders that we see? Well, first we have Tourette syndrome, which I'll define in just a minute with the diagnostic criteria. But prior to that, we have a persistent chronic motor or vocal tic. So this is one or more motor tics or vocal tics, but not both. The tics occur many times a day, nearly every day, on and off throughout the period of more than a year. Tics that begin before the age of 18, and the symptoms are not due to another disorder, and they don't have Tourette syndrome. And then we now have what's called provisional tic disorder. And provisional tic disorder is where you have the same thing, one or more vocal tics, but not both, and they haven't been present for a year. So when a patient comes in and they've had tics for several months, we label this as a provisional tic disorder. If patients come in and they have both motor and vocal tics and they haven't had them for a year, as you'll see in a moment, we typically don't diagnose them with Tourette syndrome, but it's very clear at that point when you have both motor and vocal tics, it's very likely that you're going to develop Tourette syndrome, that this will continue. Again, provisional tic disorder is before the age of 18, and the symptoms are not due to another medical condition. So when we talk about the diagnostic criteria for Tourette syndrome, as I mentioned, you have to have multiple motor and vocal tics, though they don't have to occur at the same time, and they have to have been present for at least 1 year. The tics can occur many times a day, usually in bouts, nearly every day, or on and off. The tics begin prior to the age of 18 years, and this is what we use for diagnostic criteria, but I need to mention that we do see patients who have adult onset Tourette syndrome. And adult onset Tourette syndrome sometimes is actually more severe than when it occurs younger in life. But we do see it over the age of 18, though we typically don't use put those patients into clinical trials because they don't meet the diagnostic criteria that we've used to define it. They also have symptoms that are not due to taking a medication, so there are many medications that can cause people to have tics, such as stimulants. Stimulants can cause normal people to have tics just because of the nature of the medication and the side effects, or other drugs are due to having any other medical condition. As I mentioned, tics occur, they're somewhat elusive. They occur in bouts, which James Leckman in his publication in Lancet in 2002 coined the term bouts of bouts of bouts of bouts of bouts. And so as you can see, tics occur randomly. They occur at various, when we look at various time courses, you can see here on this illustration, seconds, hours, days. What I used to say to people was, you can have good days and bad days, and you can have good weeks and bad weeks. You can have good months and bad months, and you can have good years and bad years. And so it's virtually impossible to predict with any certainty what people's tics are going to do in the future. So the tics come and go. They're often worse without clear triggers. But we do have some triggers that we know on a regular basis will exacerbate tics. And these are commonly worsening with stress, anxiety, or fatigue. So we see that frequently in children. In the evening time with fatigue, they may tic more. With stress, with school projects, they may tic more. Tics have a waxing and waning course that is impossible to predict with any certainty. And this makes it extremely difficult when you're treating patients. If we put a patient on a medication and their tics seem to get better, it's very difficult to say that that was clearly the medication or whether the patient was just going to have a waning time with their tics. Such that the tics were going to get better on their own. So you have to be very cautious. Likewise, you have to be very careful about not adjusting medications at the first sign of an increase in tics. Tics can occur sometimes can increase with concurrent illnesses. As I say, they increase with stress or anxiety. And so if you adjusted medications at the first notice of any increase in tics, you would quickly have a patient on more medication than they actually need. And so frequently when I get a phone call from a parent or from a patient with an increase in their tics asking for an adjustment in their medication, I may ask them to call me back in a few days, or I may ask them to call me back in a week to tell me whether the tics are still significant, because it may be that it was just something that happened, some stressful situation that was causing the tics to be worse. Tics will actually, so the disabling nature of tics, when we talk about the disabling nature, often the tics are not always as obvious as they seem. And so the problem is that though tics can be disturbing to patients, it's often the mental energy that you expend to suppress the tics and premonitory urges or urges alone that are tremendously more disabling than the tics themselves. So if you are in school and you're trying to suppress tics when you're in school, which often happens, then basically you're not going to be able to pay attention the way you should in school. Likewise, when you get off the school bus at home, you're going to release your tics. And so, often I'll have parents come in and with their child who's been having tics, and they'll have gone to the teacher and they'll say, how long has my child been having these abnormal movements? And the teacher may not notice it. She may say, or he may say, well, I've not noticed that your child's ticking. And the parents will come to me and they say, I don't think that the teacher's even watching my child because they don't even know that they're ticking. In actuality, what's happening is the child's suppressing his tics during the entirety of the school day and then gets off the bus at home and lets loose at home, because they're in a safe place where they feel that they can tic without without somebody kind of looking at them and noticing the tics. And so that's a very common thing that we see as far as tics in school. And you can imagine if you have these premonitory urges which precede the tics, they interfere with attention and focus just like tics do, and it's only exacerbated by an effort to suppress them. So when we try to suppress the tics, it requires mental energy, and that mental energy that we use suppressing tics is going to take away from the mental energy that we should use focusing on other things, such as school children focusing on the class. And tics will only increase in frequency when they are brought to somebody's attention and to the focus of conversation. This is very common in the office when we begin talking. Child will come in to see me and won't be ticking initially, but then once we start talking about their tics, they might start ticking more. Many tics can be physically uncomfortable in addition to the mental energy that's required to either have the sensory urges or to suppress the tics. We see patients who have severe neck pain from neck snapping or head tossing that over time can cause severe arthritis and even spinal cord injury. This has been a common thing. I think that Roger Curlin first kind of looked at this situation. When I started practicing early, before we really started looking at this, patients would complain of neck pain because they had a neck tic or a head snapping, and you'd say, well, of course your neck hurts because you're making these funny movements with your neck. But in reality, over time, people can definitely hurt their neck, and so we now pay more attention to it. I think we do more MRI scans on people, and I've had a number of patients who have actually had to go to surgery later in life because of the severity of their tics and what it's caused as far as arthritis. We see constant throat clearing and coughing that causes pain and irritation. I've had patients that have felt as though they couldn't breathe because they were coughing so often. I have patients who have difficulty going to school because of the constant coughing, and that can be physically uncomfortable as well. We have severe eye pain that can occur from squinting or blinking, causing eye pain or irritation. We have patients that have tooth trauma from snapping their jaw shut, and then also patients who punch or slap, causing injuries, either punching themselves or slapping others, which can be a problem. So the associated behaviors of Tourette's syndrome are perhaps the more disabling part of things. So when we look at the tics are often less disabling. Premonitory sensations or sensory urges can be somewhat disabling, but the associated behaviors that I'll mention are typically the things that are most disabling for Tourette's syndrome. So we see inattention, disorganization, hyperactivity, and impulsivity, otherwise known as attention deficit hyperactivity disorder. And as I've mentioned, this is called hyperkinetic disorder. So if you're looking at papers or looking at journals in the European community, this is called hyperkinetic disorder. And so if you ever see that term, that's where that comes from. We refer to patients with Tourette's as having a sticky brain. The sticky brain part is this hyper-focusing or difficulty letting go, where they just can't release a child, where they focus on their shoelaces being perfect and the school buses beeping outside. These are difficult things. So the sticky brain is where you get these thoughts stuck, and you have to kind of finish these things that you're doing. Obsessions and compulsions are often very common in Tourette's and often very difficult. In talking about the obsessions and compulsions, I talk about obsessive-compulsive behavior versus obsessive-compulsive disorder. The real difference between those two terms is kind of the magnitude of the behavior and whether it's disabling or not. So we consider obsessive-compulsive behavior as not necessarily disabling, but when somebody has a disabling feature because of it, or they are seeing a physician or seeing somebody to treat it, we typically will call that obsessive-compulsive disorder because it's reached that level of disability or of magnitude that it's causing those problems. Chronic anxiety is common with social, generalized, or specific phobias. I will always ask when patients come in with children whether their child is a worrier, not a warrior, but a worrier, whether they worry about things. And frequently children have significant anxiety, again, social, generalized, or specific things, worrying about their family members being injured, and will have very frequent anxiety. Emotional instability or lability with dysregulation of affect, which is otherwise considered mood swings or labile moods, are common. Mood disorders such as depression, dysthymia, bipolar disorder. Mirror phenomenon, which I mentioned earlier, such as echolalia or palilalia, or echopraxia, which is mimicking somebody else's movements or behaviors. Learning differences or disabilities. Difficulty with executive function, which is extremely common and often associated with obsessive-compulsive behavior or disorder, as well as ADHD. These patients have difficulty with function. Sensory processing issues, and poor impulse control. Poor impulse control is failure to resist temptation, where someone has difficulty essentially with impulsivity. So when we think about Tourette syndrome and the associated behaviors, we think about Tourette syndrome as being the intersection of these associated behaviors, as you can see in Joe Jankovic's diagram or figure that he used in his publication. So it's Tourette syndrome is the intersection of these associated behaviors as well as other behavioral issues such as poor impulse control, conduct disorder, oppositional defiant disorder. These are the things that we see that are all part of Tourette syndrome and often the more disabling feature of Tourette syndrome. Why is it important to identify these behaviors? The associated behaviors are often more disabling than the tics, as I've mentioned, especially in children and adolescents. This is perhaps the most significant thing when I see patients in the office, when I see a child, a new patient in the office. Even if they don't have the associated behaviors, if I see a 4-year-old or a 5 or a 6-year-old who's having tics or who I think has Tourette syndrome, if they're doing extremely well in school, I will always bring up with the parents the associated disorders, because the key thing is to be aware and to be informed about these, because often they won't show up early, or even if they are present, they won't be interfering with the child's ability to function. So often you see these as very significant, and at some point in time, even if a patient doesn't have difficulty with this when they're first seen, they at some point will develop a problem with one of these associated behaviors, and so you must keep an eye on this constantly. ADHD accounts for almost all of the aggression and delinquency seen in the TS population, so that TS-only patients who don't have ADHD show the same rates of these problems as control populations. So you can see the importance of ADHD when it comes to these behaviors in school. Academic, social, occupational difficulties seen in ADHD plus Tourette's is virtually identical to those in the ADHD-only patients. So again, the Tourette's is not the issue with these problems. It is typically going to be the ADHD. And while ADHD is highly comorbid with learning disorders, TS-only patients do not have higher rates of learning disability or learning disorders than control populations. And also ADHD carries a significant risk for lifelong psychiatric morbidity in TS, and so that patients who have ADHD as well will have more lifelong issues with this. 50 to 90% of patients with TS who present for treatment will exhibit signs of ADHD and accompanying ODD, or oppositional defiant disorder, or conduct disorder. And the community prevalence of ADHD is 5%, and the rate among children with tics is roughly tenfold that of the general population. So you can see that when you're looking at children with ADHD, very commonly you need to look to see whether these patients also tic. This is the problem that we had early on when in the early years of using stimulants for ADHD. Frequently what would happen, and as you'll see in a minute when we look at the timelines, is that children would be started on a stimulant for their ADHD, which was identified early, and they hadn't been ticking yet, and then at some point in time the child would tic. The stimulant would be removed and the child would continue having some tics. And so there was a concern early on as to whether or not the stimulants were contributing to the development of tics, which is not the case. It just was a phenomenon that the child was going to develop the tics anyways, and the stimulants brought that out. So when we talk about Tourette syndrome and obsessive-compulsive disorder, about 50% of patients with Tourette's will exhibit symptoms of obsessive-compulsive behavior or disorder. Obsessive-compulsive behavior and obsessive-compulsive disorder are an anxiety disorder, and they're characterized by recurrent or unwanted obtrusive thoughts and images or obsessions, and or repetitive behaviors or compulsions that are done with the hope of preventing or reducing obsessions. So you don't have to have both. Some people have some people have only obsessions, some people have only compulsions. Typically you see them both together. What we talk about with OCD are children or people performing rituals that provide some temporary relief, but not for long. And patients not performing the rituals causes a significant increase in anxiety. So you see this in patients who have to do certain things before they go to work, have to do certain things before they get dressed, have to do certain things before they play sports. And these things, if they don't do those things, there's a sense of anxiety or a sense of ill will in not being able to do these rituals. The rituals can interfere with daily life and be isolating and embarrassing. So I have numerous children who have rituals where they'll go down into the basement and do something in the basement, playing or doing whatever that is a ritual for them, but it's embarrassing for them to have to continue to do this, and they'll do it in places where other people aren't around. They'll often do it in their bedroom behind a closed door. And so these things can be problematic for them. Some common problems that you see in school as a result of obsessive-compulsive disorder include difficulty transitioning from one activity to the next, not completing work or drifting to another activity. So you have to constantly refocus children in school, where if they're given an activity, say, that lasts 30 minutes, they may spend 10 minutes on the activity and then somehow drift to another one. So teachers will have to redirect the student by just coming by the desk and asking them what they're doing and kind of redirecting them to get them back on track. We see children that do constant racing. This can be a difficulty with homework, where they can spend too much time doing their homework because they want it to look perfect, or they can have an inability to tolerate mistakes, which is a similar nature. So in managing Tourette syndrome and obsessive-compulsive disorder and ADHD in school, we talk about difficulty with organizational skills and executive function. They're heavily impacted by both the ADHD and the obsessive-compulsive disorder in children and adolescents, and impact their educational performance. So you see this as impaired attention and focus with easy distractibility, difficulty with short-term memory, difficulty starting and completing projects or staying on task. Children sometimes will talk about extended time for testing, which are some strategies that we use to help with ADHD and OCD in school. Children will have difficulty with testing, where they may be easily distracted by a noise or children making other noises. They may have difficulty just because of their environment, so you can take a test either in an alternative environment, or you can have extra time for testing sometimes. An extra set of books at home often will be helpful. Reducing the amount of homework, so that if a child has a huge amount of homework, you may say only answer the odd or even answers and do half of the homework because the homework takes too long for them to complete. The same with projects. If somebody has to do a number of projects, they may limit or reduce the number of projects. emailing assignments home each day, allowing children to step out of class when necessary. So rather than a child having to raise their hand and say, can I leave the class, the child with Tourette's who has to get up and step out every so often just to kind of release some energy may do that. We talk about having a safe place for children to go to when necessary, or a safe person at school, such as a counselor, where if the child feels that they're having an exacerbation of their tics or their anxiety, they can go to a counselor and sit with them in their office rather than sitting in the classroom where they're just building up their anxiety. Again, reassuring that a child's staying on task. Audiobooks are very helpful because many children have difficulty with focusing when they're reading. I call this sometimes thought protrusion. So you read and you get to the bottom of the page and you realize that you don't remember what you just read. So audiobooks sometimes will help this. I know they did with my daughter quite well. So what is the common timeline that we see in Tourette's syndrome? So ADHD presents earlier than tics, usually at 4 to 6 years of age. Simple motor tics begin at 6 to 8 years, with vocal tics beginning a year or two later. Obsessive-compulsive behavior and OCD typically will present shortly after tics at 7 to 9 years of age. And ADHD and OCD remain as lifelong as they are personality traits, whereas tics typically will peak around puberty. And so that we see tics peak around puberty and then they essentially will wane after that and get better. So this is a timeline that James Leckman has, which I think is a very good graphic to show this. Essentially the tics peak around puberty and then get better in the late teens and into the early 20s, whereas hyperkinetic disorder, or ADHD, remains throughout life, as does obsessive-compulsive disorder. I should say that the disability from both ADHD or hyperkinetic disorder and obsessive-compulsive disorder, the disabilities change. So as adults are more able to cope with them or to compensate for them than children are. So you see that later on in life they become less significant from a disabling standpoint. So just briefly to mention where the problem in the brain is related to TS. There's various neurotransmitter hypotheses. So we talk about dopamine, serotonin, and norepinephrine. Most of these are based on the response to medications that we've seen over the years. So it's very clear that these medications, that we see these responses, and because we see these responses, it indicates to us that there must be some issue regarding neurotransmitters. We see the basal ganglia in Tourette syndrome. The basal ganglia are essentially where we where we kind of form habits or learned behaviors, and so this is perhaps the key in Tourette syndrome, or the basal ganglia. They facilitate the learning of appropriate context-dependent motor behaviors, and this can be positive or negative things, and so there must be a defect in the basal ganglia related to this, and it's extremely complex circuitry that we see with the basal ganglia that's extremely complex and difficult to understand, I think. We see that there's also the prefrontal cortex has been implicated in not only Tourette syndrome but also obsessive-compulsive disorder and ADHD. So in looking at the principles of intervention in trying to define how do we work with patients with Tourette syndrome, and how do we help patients with Tourette syndrome. So first off, I think it's necessary to clarify the clinical syndrome, exactly what we're talking about. Patients with Tourette syndrome, again, it's the tics that bring patients into the office, but it's often the other features of Tourette syndrome that are more disabling. You know, this is something that I've tried to get across to patients over the years. Usually it's more in adults where I'll have patients come in, say an adult with tics, and they want their tics treated, but yet their obsessive-compulsive behavior is out of control and disabling for them, and their family is a wreck because of the obsessive-compulsive behavior. And it takes time to convince a patient that actually it's not their tics that are the most significant thing for them. It's probably more of their obsessive compulsiveness. We talk about targeting specific symptoms. So exactly, do we want to treat tics? Do we want to treat obsessive compulsive behavior? Do we want to treat ADHD? Do we want to treat other behavioral manifestations? And so we have to consider exactly what it is that we're trying to treat. So we use medications only where there's significant disability stemming from the symptoms. So just because somebody has tics, we don't have, none of the treatments that we have, as I'll mention, are curative. The treatments are all symptomatic. And so we want to make sure that patients realize that the medications will help them for the time that they're taking them, but they're not going to change the natural history of the disorder or of the behaviors necessarily in a specific patient. We consider the comorbid conditions in the choice and priority of any interventions, whether they be medications or whether they be therapy. And we always employ a multimodal treatment approach. So when we talk about this, we talk about educating the child, family, the school, the community, parent and teacher training, behavioral management, school interventions, as I mentioned, cognitive behavioral interventions, medications specifically to target specific symptoms perhaps, social skills groups, support groups, complementary treatments. So in talking about a multimodal treatment approach, I just always mention the pediatric OCD treatment study that was that Penn participated in many years ago. This was a randomized control trial where they took patients who had, it was for obsessive compulsive disorder, but just to point out that many of these patients also had Tourette's syndrome just because of the frequency of obsessive compulsive disorder in Tourette's syndrome. But what they found was that they looked at patients, this was a study looking at the treatment of patients with sertraline or Zoloft, or treating them with cognitive behavioral therapy, or treating them with both. And the basic message is that patients who were treated with both cognitive behavioral therapy and sertraline did the best. But the patients who did the second best were patients who were treated with cognitive behavioral therapy and not patients who were treated with drug alone. So it's important to understand that we can't just use medications alone without considering using other types of therapies. When we talk about the pharmacologic therapies for Tourette's syndrome, again, we have to realize that all of the medications for Tourette's syndrome are related to behaviors that are related to behaviors. They're all symptomatic treatment. So we only use these medications to mitigate symptoms. It's not curative. So again, I tell patients and families all the time that whether we start the medication today or whether we wait to start the medication in 6 months or a year, it's not going to change the natural history of the disorder for that patient. So medications are chosen to treat a specific symptom that's disabling. You don't use a medication, we never would want to use a medication where the side effects of the medication were potentially more disabling than the problem that we were trying to treat. Some medications may be effective in treating multiple symptoms. A good example is guanfacine and clonidine. These medications treat not only tics, but they also will treat symptoms of ADHD as well. So the common medications that we use for tics include, as I mentioned, clonidine and guanfacine. We use topiramate, which is a substance that we use for medications used for seizures, and it's also used for migraine headaches, and it also works for tics. Risperidone and aripiprazole were medications that are considered atypical neuroleptic medications. These are medications that were designed following the use of Haldol that don't have the same side effect profile as the neuroleptic medications, which are the Haldol, Pimozide, and fluphenazine. We use these medications much less frequently than we used to, and that's because we have the atypical neuroleptic medications now. Fluphenazine has perhaps had a little bit more comeback as far as using it, in that we found that it's extremely effective in patients, and perhaps it's one of the more common neuroleptics that we're using these days. Common medications for ADHD include clonidine and guanfacine, as I mentioned. Atomoxetine or Strattera is a non-stimulant medication that can be used for ADHD, and then we use the stimulant medications, the methylphenidate and amphetamine compounds. Common medications for obsessive-compulsive behavior include the SSRI, or selective serotonin reuptake inhibitors, and SNRIs, or the serotonin norepinephrine reuptake inhibitors, which are a class of antidepressants that not only treat depression but also treat anxiety and obsessive-compulsive behavior. And then we use clomipramine or anafranil as another medication that can work for obsessive-compulsive behavior. Non-pharmacologic therapies for Tourette syndrome include things like habit reversal training, which is awareness training, self-monitoring, competing response training, where a movement is performed that is opposite to a particular tic. And then a bigger therapy is the comprehensive behavioral intervention for tics, or CBIT, which is a similar therapy where it increases awareness of tics and the urge to tic. So it probably involves more of the premonitory sensations or sensory urges. Again, training to do competing behaviors when the urge to tic is felt, and changing day-to-day activities that can be helpful in reducing tics. So it's kind of combining somewhat of the habit reversal perhaps, but in addition, the cognitive behavioral therapy. We use cognitive behavioral therapy. I apologize, that should be cognitive behavioral therapy, is the mainstay for non-pharmacologic treatment of obsessive-compulsive behavior and anxiety, and is also valuable, can also be valuable in treating ADHD. Neurofeedback for ADHD, we see typically involving computer-based programs providing feedback regarding attention levels to promote self-regulation and to enable behavioral training. So I want to thank everybody for the opportunity again to speak tonight. I want to thank the New Jersey Center for Tourette Syndrome so that I could talk about the life cycle of tics and perhaps help with some personal insight into tics and to the associated behaviors. This is a picture from Africa where I work at some of these rural clinics in treating kids and adults. And I have my contact information on the slide so that people can, if people have an interest in contacting me for what reason, those are my contact information. So I do appreciate the opportunity, and I'll turn this over to the New Jersey Center for Tourette Syndrome.
Wow, well, thank you for that enormous amount of information, and we have such a queue of questions here. I'm not quite sure how we're going to get to them all, but we will definitely take a stab at it. So I'm going to start right away with a question that was asked several times, different people phrasing it in a different way, but they all have to do with the occasions of tics with Asperger's or autism. So could you talk about that a little bit?
Sure. I think that the what we've seen over the years is that we've seen this. This has been a common thing, and that early on, many of us took a fairly firm stance that we would say that this was Tourette-like behavior occurring in a condition, say in whether it be in Asperger's or whether it be an autism spectrum disorder, whether it be in children with cerebral palsy, and we would say that this was Tourette-like activity. And I think we've taken a little bit of a different stance. And the bottom line is that the genetics of Tourette syndrome is such that it's not as clear-cut as what we thought initially in looking at this, that we thought initially this was a fairly simple autosomal dominant, meaning that one, you know, that if you had Tourette syndrome, there was a 1 in 4 chance that, I mean, I'm sorry, a 50-50 chance that each child would have Tourette syndrome of any parent. And what we've looked at now is that it's probably a more complex genetic makeup. And so I think that when we see this now, we know that Tourette syndrome, all the features of Tourette syndrome occur in a higher incidence in children with autism spectrum disorder. And I think that's pretty clear. And I think we see clearly children with other brain injury that will also have similar features. So we treat it the same, and we treat the symptoms the same. So I think it's a little bit less trying to label things and more trying to look at the specific symptoms that we're treating.
Okay. All right. Thank you. Have a question. Someone is asking if you could talk about how out of the box, that's in quotes, things could help, such as animals or playing music and so forth. This is help obviously with tics and TS.
Right, right. So I think that that is kind of, you know, I mean, that's something that would be looked at in therapy and would be an individual thing. So it would relate specifically to the issue of anxiety, stress, so that if you had, you know, we know that that animals like dogs or cats or pets are extremely helpful in reducing stress in anybody. And, you know, when we look at, you know, how we measure, kind of monitor stress and do those things, we see that that patients relax greatly when they're around a dog or around a cat. And so using them in that fashion to reduce stress would certainly be effective. I think that would be, you know, to the extent that one would use that would be really individualized. I think that you could also use many other activities. It's interesting that I see, you know, in this kind of, you know, in mentioning that, I also see patients who come in, and it's very interesting that I have parents who come in that swear that their kids do not tic when they play video games. And then I have other parents who come in that tell me that their kids tic tremendously more when they play video games. So obviously it has to do with how one individual responds to a specific activity. So if it's video games, there's some kids who are more relaxed and focused when they're playing those and they don't tic, and then there's some kids who are more stressed when they play video games. I think the same thing would be true for anything like animals or behaviors, but I do think that we know that animals do reduce stress.
Would it be a safe thing to say that anxiety is kind of an underpinning of a lot of what goes on with Tourette, and when kids get anxious over, you know, trips or vacation or grandma coming or anything like that, that can exacerbate things?
I think that I frequently refer to anxiety as being the generator for this whole thing. So I think that there's no question that anxiety, whether it be in relation to obsessive-compulsive behavior, whether it be in relation to tics, or whether it be in relation to ADHD, that anxiety, as you say, is the underpinning. It's what really drives this whole thing. And so, you know, stress and anxiety reduction greatly enhances, you know, tic reduction and you know, allows people to function much better.
Mm-hmm. Had a question having to do with the idea that, you know, things, I'll use the example given here as socks, you know, how socks bother kids, or tags on clothes, or something like that. So what is that sensation actually? Is that a tic, or is that just this irritant that becomes more of a problem just because it's an irritant, but you wouldn't put it in the classification of a tic?
Well, it's kind of like what I was mentioning as far as the, the premonitory sensations and sensory urges. So again, it's that issue of, how the brain kind of perceives those things and how we, the brain in a normal person would just filter that out. So like a normal person would say, oh, that tag is kind of feels funny, and then it would be gone. Their brain would filter out that sensation, would suppress it naturally so that it would never reach the level of consciousness for that individual. But in a Tourette's patient, what they feel is they feel that tag is bothering them. It's like an itch, and it doesn't go away. So it continues. So it's kind of like that bug crawling on your leg or the ant crawling on your leg, and it just continues, and you can't get rid of it. So you can't put it out of your mind. And then what happens is that develops into essentially a habit or a tic, so that they may have to adjust their socks just perfectly. So there's two things. One is like an obsession compulsion. So there's people that have to have things adjusted right, like your shoelaces just perfectly even. That's a different thing. That's an obsession compulsion. But if it's a label kind of bothering somebody or clothes bothering them, I think that really is part of the perception, part of that premonitory sensation or sensory urge, where you kind of feel these sensations that then kind of become or create this kind of tic. Now, I should say that you can see, tag phobias in little kids. So, when you look at the graphic that I had where you're looking at the obsessive compulsiveness, there's a little blip around 2 to 3 years of age, and that is because, many kids have these tag or clothes phobias that don't necessarily have Tourette syndrome, that don't necessarily have those problems. And so you do see that, and it may be that there's a time in development where this may be something that just occurs naturally in many patients or many people, and they don't necessarily have Tourette syndrome. But in Tourette syndrome, it continues and it doesn't go away.
Okay. I had a question about palilalia, and so the question is, there's this child and he repeats something over and then he'll repeat it again, but if we don't respond to it, it's like he isn't sure if we heard it. So is it more that he doesn't think we heard it, or that he changes his tone? But does that all fall under that category if he keeps harping on the same thing?
Yeah, that's a tough question. And I think that would be my feeling is that it typically doesn't require a response from somebody else. So when you repeat things or when you say things, it's more self-stimulatory, so that it doesn't require a response from somebody else. So I'm not sure that they would be looking for, like, to notice, did you hear something? I think they're just saying it because it's stimulating, it's a self-stimulatory thing where they say it and they hear it. So I don't think that it would necessarily play into that. I don't think it would be that they're looking for a response and that's why they're continuing to repeat it.
Okay, so it's typically not a question. It's
yeah. I mean, I haven't come up with that often. I mean, when I see kids that repeat themselves or repeat other people, it's really, when I see people that do that, it seems in my experience that has been more that it's for themselves that they're doing that. They have this urge to repeat those things, and it doesn't require a response from anybody else.
Now that situation can be very problematic in school. If there's a child in a classroom who repeats the teacher or keeps repeating himself, it can look like behavior.
Sure.
And complicate things definitely in school.
Sure, absolutely, and I think that you then have to look at mechanisms of through kind of doing cognitive behavioral therapy in trying to figure out ways that you can kind of lessen that effect itself. And I should mention, you had asked me before to comment on whether something's a behavior or a tic. And so that kind of brings that up, and I failed to mention that during my talk, and I think that that's a very difficult one to tell whether something's a behavior or a tic, to the degree that I think we often will say that that it doesn't, you can't, it's hard enough to tell the difference between a behavior and a tic, that you have to kind of consider that it's all part of Tourette syndrome, and that you have to figure out some way to deal with it, whether that's through behavioral therapy or whether, you know, how you do it. And so I think it's difficult to look at punishment. It's usually better to look at behavioral therapy.
Okay. I have a question about a school-age child. Doesn't give an age here that I can see, but basically the child is able to suppress tics in school and seems to have no problem concentrating or participating in school. But when she gets home, she's easily distracted, has trouble sticking to her tasks, and so forth. So there seems to be this difference between how the child is able to function in school and then at home how distractible the child is. So the question has to do with, is that because she's concentrating on suppressing tics in school and really working at it, and then when she gets home it's kind of all over the place?
I mean that would be my take on it, would be that the child, you know, they're doing well in school, but it's taking a lot of effort on their part, and it's extremely stressful for them to do that. Even though it's not manifesting as what we would see as stress, it's building up that when they get home, that then they just, you know, they're just pooped from the day of doing that, and it becomes very difficult for them. And I think that's something that we see commonly.
I've always kind of maintained that there's a cost associated with suppressing tics, and the cost is that you can't possibly be present to everything that's going on in the classroom. So it takes a huge amount of effort to do that and be present to the lesson.
Yeah, and that's why, you know, when I see, you know, sometimes that's the issue, as I mentioned, about when you're looking at about medications. You know, I'll frequently have, because you know, honestly, I mean, parents don't want to have their kids on medications if possible, and so people, you know, we're reluctant to start medications on kids, and I certainly agree with that. But sometimes I'll see kids where I can tell that the child, I can see it in the office, that they're ticking enough that I just can't imagine that they're able to you know, be present 100% of the time, or even a good percentage of the time in school, and so that sometimes trying to suppress the you know, tics, I shouldn't say suppress the tics, but using a medication to treat the tics so that the tics are occurring less and the sensory urges are occurring less is significant in improving the ability of children to perform at school. And so when we do that, you know, we typically will always start with medications that I say, I use the term less toxic. We usually use the older medications. Something like clonidine is what I use as the initial medication, clonidine or guanfacine. I'll use that because they're very old medications that are extremely safe, and they'll be beneficial from a standpoint of at least reducing the tics to a degree. They're not the most effective medicines, but they're the safest medicines, and if they work, it's great. If they don't work and we have to go to other medicines, then that's fine, but it's almost always the first medicine that I'll use.
Mm-hmm. Okay. You mentioned something called sticky brain, and so have a question for a little bit more explanation on that.
So the sticky brain is the idea of this, of getting something, of like how tics are created, if you think about it. So when we see this all the time, and you know, and I feel it, and people who have Tourette's can explain that, but it's basically where you either see somebody doing something that may precipitate a tic, or there's something that is a sensation that develops that may develop into a tic that you have, and it's because this thought or this sensation kind of gets stuck in your brain, and it just kind of like cycles. Whereas again, a normal brain, it just kind of evaporates and it doesn't create a habit or it doesn't create a tic, whereas in a Tourette's brain it kind of like grabs onto it and doesn't let it go, and it just continues to go until it burns itself out, and that's kind of the life of a tic in a way. So a tic occurs, a common one that I'll mention is that we see this all the time, is that children or anybody who develops a cold or a upper respiratory infection and they're coughing, a person who has Tourette's will continue coughing for tremendously longer than a person who doesn't have Tourette's. And the reason is they get this, it becomes a habit. And the coughing just becomes this habit, and they may cough for weeks, whereas a normal person, the cough would have been away as soon as the upper respiratory infection was cleared up. And so the tic kind of like bounces around in the brain and just cycles until it eventually just kind of burns itself out and goes away, and then it's replaced by another tic. And so that's kind of the sticky brain. It's this ability to grasp, to take something and to just not let it go, and that's what becomes a habit.
Okay. I have a question about, can tics be dangerous to the brain or as dangerous to the brain as seizures?
No.
Okay.
So yeah, no, it's just not the same thing. So seizures, the reason seizures are dangerous is that seizures are essentially a massive outflow of activity that occurs, and so it's essentially the cells in the brain become overutilized or overexcited, and so you can have damage that occurs, not only damage that occurs by propagating seizures, so that you know, when you continue to have seizures can be more difficult to treat the more you have, and prolonged seizures can also damage the brain from a standpoint of metabolic problems. Tics don't do that. The reason is the tics are a manifestation of an underlying problem that exists in the brain, or underlying abnormality of the brain that's causing these, and so the tics in no way kind of create a problem that occurs going forward.
Okay, thank you. We've gone well over. I'm going to ask one more question and then we'll have to wrap it up, okay? Are there certain types of learning disabilities that tend to come with Tourette and OCD? Is there any evidence that there are similarities there? In your judgment, obviously.
Yeah, well, I think the learning disabilities that I think we see numerous learning disabilities that occur. We see all of the learning disabilities are frequently seen not as part of the Tourette's, but again as part of the associated behaviors with the OCD and with the ADHD for the most part. So we see, and those are all learning disabilities that occur in the setting of patients who have difficulty with attention and focus, or difficulty with obsessions and compulsions, and those can be any of the learning disabilities that we see, and those are very common in patients that have the full spectrum of Tourette syndrome, where the associated behaviors are significant.
Okay, thank you very much. We're going to end it here. I'm going to turn this back over to Lisa to just close out the webinar, and thank you, Dr. Rubenstein. That was great.
Thank you.
Thank everyone for attending.
Thank you for joining our webinar on the life cycle of tics. There is an exit survey which we need everyone attending to fill out. The webinar blog is now open and available for the next 7 days on the NJCTS website for additional questions that were not covered in tonight's presentation. That website is www.njcts.org. Also, an archived recording of tonight's webinar will be posted to the site. Our next presentation, Demystifying DSM-5 Diagnosis, What Parents and Educators Should Know, presented by Dr. Colleen Daly-Martinez, is scheduled for March 15th, 2017. This ends tonight's webinar. Thank you, Dr. Rubenstein, for your presentation, and thank you everyone for attending. Good night.